Hey, what's up? Welcome to the Birthing Podcast. Little teaser today. We're going to talk about erythromycin ointment, so eyes and thighs. Yeah, about me personally, just working hard to get licensed and ready for the home health agency. And this one is going to be based in Simi Valley, Ventura County. And then I want to expand to Los Angeles and Santa Clarita. This has always been a dream of mine, always since I started in medicine in school, to be able to support families before birth, after birth, in a more extensive way. I just don't, and I don't know how you feel, but I just don't think during pregnancy and, our education and the medical support that we receive is very good. Like, it needs to be better. I think we all agree that a 15-minute meeting with our doctor, if you get that, is enough. There's so much that they do not tell you. Like, we can't, they don't plan with you. How are you going to plan for your pregnancy, for your birth and postpartum and bringing home a newborn? Nothing. They'll do the ultrasound, they'll go over your labs, they'll see how you're feeling, they'll check your weight, they'll check your urine. And then if you really have any concerns, you got to call the office or email them, and then it's going to be a quick reply, and you don't have a lot of eyes on you, right? So yes, I'm starting out by coaching. So you have your own nurse. Do you want your own nurse to just have someone to contact, to text, to message, to chat with once a week about your feelings and what you're going through? Why not? I'm here for you. That's why it's called My Friend's a Nurse. So that you can say my friend is a nurse. It's not for me to say my friend is a nurse, so I do have friends that are nurses. It's for you to say my friend is a nurse and I can talk to her. It's I want to change this mentality of healthcare a little bit so that you feel supported, that you have someone to go to with questions and can be part of your team alongside your doctor, right? So you deserve that. You can find a doula. You can have someone to support you at the bedside during birth. That's great. But there's something to be said about someone who is more in the medical side of things, right? I have a understanding, and so do all the labor and delivery nurses and postpartum nurses for the most part, about giving birth, laboring in a hospital system, who deal specifically with obstetricians on a regular basis in a way that doulas don't. Okay, so from fetal monitoring to medications to interventions, from epidural to nitrates to baby medications to all that stuff, how are you going to navigate that? I think there are some doulas that are really, really good at it. You can actually find doulas that used to be nurses and just left the bedside for whatever reason that I can totally understand. But, I love the bedside. I love bedside nursing. And so I just want to provide that. So I do coach you through that so that you have a nurse that you can get a hold of at any time and discuss concerns and prep for your next visit with your doctor. And maybe you had a visit and now you want to kind of maybe processed it a little bit, or there were questions that you just failed to ask. And now you're like, oh, shoot, Colette, can we have a call, or we have a group call, and then you come on and then you're able to feel that support. There's no holes, that we got to close those gaps, right? You shouldn't be left wondering, because your next appointment is in 4 weeks and you're going to forget. And then you get to the appointment and you just want them to say everything is good, and you want them to say your baby's fine and healthy. And then you're kind of feeling rushed. Well, I can't ask her the 15 questions that I have. And now you're resorting to Googling and Facebook. And I have these Facebook mom groups and newborn groups, and they're just all these moms asking all these questions to these other moms, which, you know what? I totally support. Moms supporting moms, we've been there, we get it. But again, are they medically trained? Do they really know the insides and outs? I see the miscommunication, the false stuff that they're telling each other. And I can't I'm also do I go in and start correcting everybody? No, have your conversations. I can't be that vigilante type of person to do that, but find yourself a nurse. Continue going to the mom groups, right? Continue doing that. Continue asking your friends. That's fine. And then go ahead and Google too. I'm not against it. Get all the information, right? But then how you filter it out. Sometimes that can be super overwhelming to like type in Google your question and it's like, okay. And then sometimes it's very too simple. Like it's very general answers. Like how does it pertain to you specifically? Right? A lot of things I do as a coach is asking you questions back to you so that you can answer them on your own, right? Some of it's not so black and white. Some you wish it was, I know, but let's go through it together. Let's color it a little bit. It's just not that black and white, and that's okay. So yeah, so that's what I'm doing. I'm looking for more clients now. I had a group of clients that were just amazing. They're my beta group and they're all delivering. Their babies are coming. So now we're transitioning to that newborn stage and the recovery part. But I'm looking for moms now that are pregnant, maybe delivering in, I don't know, April, May. If man, time's flying. 2025. Those babies are coming. Are you planning to deliver in 2025? Get a hold of me. Let's work together. Okay. I made it so affordable. I even make it so that your insurance can pay for it. So you have nothing to lose. Get that support. Even if it's just having someone to text and message, I get so often that just that alone was worth it. And again, it's so inexpensive. It's going to be the least of your concerns. It's almost like and remember, like if you have insurance, I'm going to help you get that coverage. But yeah, reach out to me. So I'm doing that. I'm doing the coaching and then I'm getting licensed as a health agency so that I can actually physically in Simi Valley, Ventura area, Los Angeles, send RNs to your house so that I could do NSTs and AFIs and iron infusions and all that stuff that you would normally have to like trek yourself over, leave work, find a babysitter, and then go to the hospital and get that done. I can just send a nurse to you. I don't know. Let me know. You think that's a good idea? I do. There's so much stuff that we do in labor and delivery. Like we're sitting there in triage doing these kind of tests and screenings, vital signs, diabetic teaching, all these things that we could probably do at your house. Save you time, save us time, save the hospital money, save their resources. They're always saying they're lacking resources, right? So that's my business right now. And I'm very excited about it. Something I've always wanted to do. And I wanted to share it with you because I've been so busy doing that. So hopefully, and then postpartum stuff too, of course, right? So I want to come a few days after you've given birth and check on you, check on your baby, see how you're doing. Are you feeding? Are you eating? How's your home environment? What are your risks right now for postpartum blues and depression? Can I educate you on any of that? All the education that we do in the hospital, I feel like most of it goes right over your head because you're like in this fog. You're just so tired. You're like not processing. And then, you're left back to Google and wondering like, why didn't anyone tell me? So why not have a nurse come visit you and do that? And then I can check if you had a C-section, your wound, like the incision, site, is it being infected? Let's keep you healthy. Let's keep you feeling supported. I have Billy lights, so I can bring them for your baby so you don't have to readmit your baby if they're jaundiced, and you can get those lights right in the comfort of your own home. And because my baby almost had to be readmitted, Kaya, oh my gosh, that my heart was breaking at that. Even the thought that I just got home and now I'm going to have to take my baby in. She's going to have like overnight. Has this happened to you? I know I think I saw the rate was like 2 to 3% of all babies get readmitted for Billy light treatment. So, and I think that's might go up as we are doing more and more delayed cord clamping. So yeah, that's what I'm doing, guys. I'm happy to share it with you. Let me know if you have questions. Visit my website. I'm going to start cleaning up my website to kind of start focusing on that more. Right now, it's just promoting the childbirth crash course, which we did in the beginning of November, but you can get the recording if you'd like. That's about 3.5 hours of me going into detail on everything you need to know to navigate the hospital system. So you want to check that out. And you can just go to myfriendsandnurse.com and click on the link and get that. It's $27. And of course, if you get that, then you have me too, because you can ask me a question and we can have a free call So $27, you get a 30-minute call with me. We can go over your birth plan. We can go with any questions you have. And then you get 3.5-hour birth class. That's pretty cool. And then if you need a receipt for that to get reimbursed by your insurance, you can do that too. Okay. All right. Enough of me jabbing away for the last 10 minutes. Let's get on with the episode. I'm so happy you're here. Welcome to the Birthling Podcast, presented by My Friend's a Nurse. I'm your host, Colette Colliker, a high-risk labor and delivery nurse right here in sunny California. I'm also an OB certified specialist, birth educator, lactation expert, and mother of 2 beautiful daughters. I am passionate about guiding you through the miraculous journey of pregnancy and childbirth, using evidence and history and asking the reason why. I have some incredible medical friends and colleagues, and we're all here to help you navigate this often overwhelming birthing hospital system in the United States. My goal is to gain trust in birth, improve this system, and provide some valuable insights. Let's make this journey a little less daunting and a lot more joyful. Let's get into it. Hey guys, welcome back to the Birthling Podcast. This week, let's get into erythromycin ointment. So this is part of the duo of the eyes and thighs that we give to your baby right after birth. So if you're asked, are you okay with the baby medications? You know that this is one of them. We talked about vitamin K, so that's the thighs of it 2 weeks ago, episode 16. So if you haven't listened to that one, please go back and check it out. I know it was a long, data-driven episode, but stuff you got to know. It's the history of it, evidence, all of that stuff to make the right decision. We use the acronym PIEDAY in that one, and a lot of the resources and information I got was from Dr. Sarah Wickham's book, Vitamin K and the Newborn. So make sure you check that one out, especially if, that was so much information in that hour and you're like, how do you process all of it? Get the book. A lot of that information is in Sarah's book. So get that on Amazon if you want. I've read it 3 times already, and I'm definitely going to be rereading it again because it's hard to process and retain. Some people learn better listening. Some people learn better visually. Some people learn better like just reading or doing. So kind of got to do it all. So check out the book, learn about vitamin K. If it's the right decision for you, it's another decision that you need to make for your baby. And I know you're doing it. I know you're thinking about what mattress to get. I know you're thinking about what car seat is best for your baby or what detergent you want to use on your baby's clothes. I know you're doing it right now in pregnancy. Like, what are you eating? What shouldn't you eat? You want to limit your risks of what's happening. So don't stop when it comes to birth. Don't stop when it comes to the first things that we do after birth and those first decisions that you should be making to your baby. And so many times we are just passing that on as soon as we walk through the hospital doors to our doctors and our nurses. And I know this because as soon as I ask them, are you okay with the baby meds? They're either like, yeah, it's fine, without a conversation, because I know that they're just like, sure. Because when I ask them, well, do you know the risks? Do you know why we're giving it? They blank face. They have no idea. So it's like, okay, well, we want to give it, and they're okay. That's good enough for them. Okay, maybe, you know what? Maybe it's just like decision overload for parents. You're like, I've done so much research right now on what to do for my baby. Like, can you please just make the decision for me? So your doctors are going to make it, and your nurses and the Academy of Pediatrics and ACOG, and they've all done the research, and we've done the evidence, but a lot of what they've done and a lot of most of the recommendations that we give are going to be this umbrella standard of care that we want to do for everybody, right? And without creating an individualized plan and assessing your risks. Because you have to think about it. Every intervention that we do, either with birth or a medication that we give to your baby, has its own risks, right? If you decide on a C-section because you want to lower the chances of tearing or it not being able to deliver a big baby, let's say, well, the C-section comes with its own risks. And I want you to prepare yourself. I want you to be part of the team. I want you to make these decisions so that if something does happen, you're not then living with this regret of like, what happened? Did I make the right choice? And then you're blaming the doctors and nurses, like, you did this, or this is your fault, or you're not even understanding what happened. And then you're saying thank you to us when maybe that intervention or that medication wasn't the right fit for you. Because our care can't necessarily be this like blanket, universal, one size fits all, right? So, who is going to be the best person to let us know that it's not the right fit for them? Is you. You have to be part of this conversation. Also, I want to prevent this trauma that happens when you go to give birth or you do anything and you feel like you lost control. And essentially you have lost control over your body, over decisions, over everything, over your baby. You know, if you don't make any decision and you leave it in the doctor's hands and something happens and your baby is now in the NICU, you've lost a week or 2 days or however long with your baby. And you're going to be suffering those consequences, and your baby's going to be suffering those consequences. And what happens is you feel, well, I didn't have any say. I didn't have any control over the situation. And perhaps you didn't, right? Life is lifing sometimes, and things do happen that are out of our control. And of course, that we're going to feel awful for that. But when it's preventable, when we did have control, but we just didn't put the time to prioritize it, is when you're going to look back with regret and you're going to think, what could I have done differently? Why did I feel like the autonomy over my body and my decision making was taken away from me, right? And that's what I work so hard on and so carefully with clients on to develop. So it's the education around birth itself. Yes, of course. We want to become comfortable with birth. It's also becoming comfortable with decision making, researching, and asking the right questions, right? And then it's developing these skills as a leader, because you are the leader of your body and your birth and your baby and that birth room. So we need to develop those leadership skills, and it involves communication, and it involves understanding what your goals are, what your values are, what are your preferences, what is important to you, right? And then creating a team around you that can advocate and back you up, right? Because gosh, it's the worst when you say something and you stand up for yourself. You're trying to advocate for yourself. You say, no, I don't want this. Maybe it's a cervical exam. Maybe it is a medication. You're like, no, I don't want this. And then you have a partner that doesn't understand what you want, your preferences, because you didn't communicate it. You didn't write out a plan, right? And now you're arguing in there with them about a decision that you want to make, and they're not backing you up. They're going to maybe side with the doctor. They're going to kind of help gaslight the situation, make you feel like you're at fault for even standing up for yourself or declining something that you just do not feel comfortable with. And now it's like, man, you're like up against a wall. You're being pressured. Or maybe you're the type of person that is more a people pleaser, or you don't want to make too many waves. You just want to try to and then you just end up in this place where you're just trying to get through it. You're like, you know what? This isn't worth the battle. I'm already suffering. I'm already trying to just get through this. This is hard enough. And now I have to like fight and stand up for myself. Forget about it. All these people that seem to know more and better than me are telling me something, and this is not the time for you to start Googling and researching and asking people, right? And so quickly it gets taken away from you. And that is probably the number one reason that women describe trauma or a loss of control in the birth space, right? They have a very good understanding that yes, birth can be out of control at times, but it's when they state there's something, it's when they say no, it's when they ask a question and then they get denied or they get, dismissed, that they start internalizing this feeling that this is like such a horrible experience. Like they're just trying to get through the pain. They're trying to do their breath work. They want to trust their body. And now the people around them that they felt were going to advocate and support them feel like they're just against them or they're not listening. And it's horrible. And honestly, I've seen it so much that I have to do this. I have to find my voice. I have to talk to you guys. I have to educate. I have to work one-on-one in a group with clients that pay me. So I give them my time. I'm literally researching birth 60 hours a week. When I'm not talking here, I'm reading, I'm listening to other podcasts, I'm talking to other experts. I've had like three interviews this week with other experts that I've never met, and I've learned. I'm always learning. I don't think you have 60 hours in your week to do this. So why not hire a nurse coach, someone like me that is doing it and that knows the inside and out of a hospital? I know how to talk to the obstetricians and midwives. I know the right questions that you should ask. I know the leadership skills that it takes to get the birth that you want. So why not work with me? Why not let me do the heavy lifting and guide you, right? So message me, get into my DMs. If this resonates with you, if you want this, if you want to feel in control, if you want to be empowered and confident in your birth, then get a coach to coach you to learn how to do that, right? I like the word coach. I won't lie. I like it. Right? We're going to work together and I'm going to improve. You've got the skills. I know you have it in you. You're going to be a mother. If you're not already, you're going to be a mother to this baby. And I know you can stand up for yourself. I know you can ask the right questions and I know you can make the decisions. Don't pass them up to someone else to do. All right? Build that team. Call me. Message me. Go to my website, myfriendsnurse.com. Contact me. Get into my IG DMs. I live there at My Friends Nurse. You can find me. I know you can. And let's work together. All right. So today you're going to learn about the erythromycin ointment. So that's the eyes of the eyes and thighs, right? You learned about the vitamin K. Now we're going to research and learn about the ointment. And we're going to find out, it's routine. We give it to all the babies. 98% of babies get this ointment. Does it work? Is it worth the risk? What are the risks? Is this a decision you want to give that you want to make and you want to give this medication to your baby? Okay, great. Is maybe not? How do you decline it? How do you have the conversation with your doctor? So let's quickly go through it using PIEDAY first. So the PIEDAY, write that down. You're going to use that whenever you're making a decision for yourself, especially about preventative and prophylactic care. I like it. Maybe it's a lot, it's six things, but we're going to get through it quickly right now. Okay. So what's the problem? The P. We are giving this ointment because of an infection called ophthalmia neonatum. This is pretty much neonatal conjunctivitis. That's another name, or pink eye. We all know pink eye, right? Our eye gets swollen, it's red, there's pus coming out, eyelashes are sticking together, right? We get it. It's not fun. We want to fix it immediately. It hurts. And sometimes we need antibiotic ointment. If it's a virus, oh my gosh. But most of the time we can treat it with a little bit of antibiotic and it goes away. And same thing with the babies. If the babies get it after birth, maybe the infection they got from the environment, like the hospital, maybe they got it from bacteria from mom, maybe they got it from home because you get it in the first 4 weeks, right? Maybe it's a blocked tear duct, right? I mean, an eyelash got a little stuck in there and the water, the tears got backed up and they couldn't come out. And now it's got swollen and red and got infected. So yes, so conjunctivitis is that inflammation of the conjunctiva. Conjunctiva is the layer of skin underneath the eyelid and over the white part of the eye. All right, just so we make that clear. It was first discovered in the early 1800s that babies born in the hospital in Europe were contracting this bacterial infection through the birth canal, like somewhere in the birth canal. They were getting it from mom as they were being born. It wasn't until 1879 that a German physician named Dr. Albert Neisser discovered that it was actually gonorrhea specifically. So that he found the bacteria that was causing this, an STI. Okay. And back then they didn't have a treatment for gonorrhea. So it was more rampant. Everyone had it. And then they were passing it to their babies. And the problem was that this particular gonorrheal infection caused severe blindness. Like, it was serious. So they needed to do something. They need to stop this. A year later, the German doctor named Karl Kried developed a treatment using silver nitrate. So they put the silver nitrate in the eyes. It didn't do too much to like treat it once they got it, but they realized when they give it to babies that didn't have the infection, it was preventing it from happening. So the rate of infection went down to one baby in like 6 months. I'm trying to scroll real quick. I have the page up from evidence-based birth. And of course, if you don't know evidence-based birth, it has so much information. They use so much research and studies from the CDC to ACOG and peer-reviewed articles. So definitely want to look it up. I can't find it. I probably should have just had it ready to go for this episode of how many babies were getting it before, but it was quite a few. No, I'm just like scrolling now. Hold on. It says back then, 10% of newborn babies born in hospitals across Europe developed this, let's call it ON, ophthalmial neonatal, ON, so I don't have to do it. The illness caused blindness in 3% of affected babies. So 1 out of 10 got the disease, and then 3% of those went blind from it. Yeah, not fun. It happens in the first 4 weeks of life. Here we go. So once they started with the silver nitrate, giving it to prevent it, they were getting 30 to 35 cases per year. And it went down to like 1 in the first 6 months. So yeah, it worked. Okay, that was enough scrolling of that. Go to the website. I'll link this actual article in the show notes so that you can read about it. I'm not at the point where I'm writing my own articles. There's so much great information out there right now. So I'm still like reading and learning stuff myself. And a lot of it I do know. So it's just kind of supporting what I know as well. Maybe one day I'll write a blog or, but hey, I'm here. We're doing a podcast, right? This is something I'm sharing. And then if you're my client, you're going to get even more. And we're going to get into more details, personalized. But okay, so yeah. The silver nitrate was working basically, but the silver nitrate was rough. It was irritating. It caused this irritation and redness, and it looks painful. They thought it was painful. They didn't believe babies like felt pain. But we know now, we can say now that it was painful. It was probably pretty painful. Back then they didn't, but they're like, oh, it did get red. But they continued on because they thought babies don't feel pain. And it was so effective at reducing the chance of getting blindness. So they kept on going. But what happens? Antibiotics. Antibiotics came into our world. We figured that out and we switched over. So we knew that it was a bacterial infection, and antibiotics are generally great for bacterial infections. So they created the ointment using 0.5% erythromycin, and that's what we use today. They tried different types of antibiotics. Maybe they weren't as effective. So they kind of settled on erythromycin. And today there's still other antibiotics you could switch to for whatever reason. Maybe you have an allergy to it and you don't want to take that risk that your baby also does. I don't know. Talk to your doctor about it. But for the most part, we give it to all the babies. It's very rare for them to get this anaphylactic reaction or allergic reaction to it, but there is a side effect of redness, irritation, and even a clogged duct. So the ointment itself can clog the duct and cause pink eye. I know. Same thing happened with the silver nitrate. When you're putting anything in that area, that's a risk. So know that's the risk of an ointment is redness, irritation, and the clogged duct, which could lead to conjunctivitis. Very uncommon, very rare, you guys. And that's what your doctor's going to tell you. And it's true. I also want you to know with regards to this infection that if you do give the ointment and they still get a severe reaction of a severe infection, they'll test it. They'll see if it is gonorrhea because another severe infection could be a bacteria called Pseudomonas aeruginosa. And yeah, that was very rare, but there's no evidence that the ointment's going to work on it. So if you gave the ointment and they still get this infection in the eyes, it may be just not gonorrhea and something else because it's very severe. But let's get more into the incidence, right? Like what's the incidence of gonorrhea causing it? What else can cause it? How many babies were getting it? So I in PIEDAY is incidence. In the 1800s, about 10% of babies were developing this disease in the first 4 weeks. So I got that, like I said, straight from evidence-based birth. And nowadays, 30 to 50% of infections, so the babies that get infected, 30 to 50% of them are bacterial that come from the hospital itself, like the environment or mom, the home environment, chemicals, and again, the blocked ducts. So half of them, it's going to be something else. And it's going to be a mild infection and we can treat it with the antibiotic. So just know that. And that's anybody could get it. You could get it. I could get it. And a newborns, right? 1% is the herpes virus. All right. So no fun. That is permanent. Once they get that, they're living with it. So be careful, guys. Be careful if you have open sores or what's going on. But again, 1%, it's rare. The rest and most common come from chlamydia. Okay, that's the most common way to get infected. And the most serious infection, again, is gonorrhea. And the gonorrhea accounts for less than 1%. So same as like a herpes virus of the reported cases, but it's the main reason that we give the antibiotic ointment because it's the main reason that leads to blindness. Okay, does that make sense? I hope so. And that's usually what I tell my patients when they come in and I say, do you know about baby medications? I say, well, the ointment we give to prevent some serious infection and blindness caused by gonorrhea, chlamydia, and possible other bacteria like staph. Okay? Because it's so serious, we do give it prophylactically. In some states, it's mandatory. It's law. And again, find out if it's law that the doctor gives it to you or is it law that you take it, right? Two different things. So do some research on your state and if you have, like, if it's it's against the law to refuse it or is it against the law for your doctor not to offer it to you? And then some states, it's completely up to you. And you maybe have to sign a waiver that you don't want it. You definitely have to sign a waiver if you don't want the vitamin K. And sometimes you need to sign the waiver of the hepatitis B vaccine, but that's not as common. Definitely for the eyes and thighs, when you recline it, you may have to sign a waiver. And that's just saying like that we reviewed it with you, that we educated you, that you understand the risks and you're declining. And that's fine. You sign it and you get on with it and you're educated. All right. So today, let's look at some more of the incidents. All right, let's see if mom, the birthing person, has chlamydia or gonorrhea at the time of birth, 25 to 50% of those babies will become infected. So there's like a 50% chance. One out of 2 babies are going to get infected if their mom has that infection. Okay, so it's not like 100% chance, but it's pretty high. Like it's a pretty good chance that your baby's going to get it if you have it. So do you have it? Will be the first question. And could you have gotten it from the time you tested to the time of birth? Another good question. Are you delivering vaginally? Another good question. If it's a C-section, that baby's not going through the birth canal. So then it can help kind of ask what your chances are, what's your risk of passing it to the baby. But let's say it's vaginal, you tested positive for chlamydia or gonorrhea, then there's 50% chance, 25 to 50% chance you're going to pass it to your baby. Okay. Today, about 98% of babies get the ointment, if not 100, but it's not 100. I'll just tell you that right now because I've declined many babies. But from the evidence that I found online, it's telling me like 98% of babies. And that goes for hospital, birth center, home birth. Your midwife is going to bring it to you, or the pediatrician's going to give it in the first visit at day 3. If you haven't seen a doctor, they're going to offer it to you, but I am seeing more and more patients declining it. And that's probably because they're educating themselves and they're weighing out their risks. They could be very low risk and say, you know what, I don't want to put anything in the eyes and risk some type of blocked duct or irritation or anything, right? And we'll go over that, why parents would decline in just a minute. So for those who are infected and pass it to their babies, there is evidence to suggest that the rates are beginning to rise again. Okay, so they do work. We know that the silver nitrate work to prevent, and then the antibiotics work really well to prevent it. Also, we do really great prenatal testing and treatment of chlamydia and gonorrhea. So all of these things are bringing that rate down. But for those babies that are being born to a parent that has gonorrhea or chlamydia, and they've been vaginal and they get it, more and more babies we're seeing like the antibiotics aren't working. So it's starting to rise again. So let's look at this evidence and how it relates to you and your baby. Okay. So now we know the incidence. Let's get to E, evidence. Does this prophylactic treatment work? That's something you want to know. Okay, cool. I know the rate of getting it. I know it's a 50% chance I'll pass it if I have gonorrhea and chlamydia. If there's a 1 in 10 chance that my baby's going to get infected in general. And there's a 3% chance that if they get gonorrheal infection, it's going to lead to blindness. You got it. So you want to treat my baby prophylactically to prevent this whole thing from happening. Does it work? What does the evidence show? Okay, so past studies show that the ointment is about 80% effective against gonorrhea ON infection and may also offer some protection against ON from chlamydia. Some evidence also suggests that the erythromycin may be effective at reducing overall bacteria in the eye and lowering the rate of ON from staph bacteria. Okay, great. The studies may be becoming dated, as we have evidence now that some strains of bacteria are becoming resistant to the antibiotics, making it less and less effective, right? We know this. The more antibiotics you get, these bacteria are smart. Like they know how to survive. They're going to change. They're going to mutate to become resistant to this specific erythromycin. If we're giving it to all the babies all the time, this bacteria is going to learn how to survive, right? It's going to mutate. So they're becoming resistant to erythromycin. So we're either going to have to figure out a new antibiotic or a new treatment, or, we're going to have to do our best to lower the cases of gonorrhea and chlamydia in general. It's kind of a scary thought whenever I think of antibiotic resistant, MRSA, stuff like that. Like Yeah, it's scary. Like we rely on antibiotics to treat us. And what happens when it doesn't work, right? Maybe we shouldn't be giving it to all the babies all the time and lower our chances of creating this antibiotic resistant bacteria. I don't know. Just a thought. This is something that happens when you just give antibiotics to everybody. So the studies, let's see, hold on. Where was I? See, I go off. I follow my show notes and I just go off on my tangent. I'm like, what was I talking about? Okay. So remember, since the most serious is gonorrhea and the most common chlamydia infection is transmitted vaginally, it's going to be very unlikely that you're going to transmit it to the baby via C-section if the amniotic sac was never broken. All right. It can't get to the baby. And if you're delivering and bypassing the vagina and where you're infected, especially if you're tested negative, then your chances are super low that you're even going to need this antibiotic at all, even as a treatment. And there's really little evidence lately because of these newer findings that's, of all of this. And the very low risk with good prenatal testing and treatment that any of the states really should be continuing to mandate that all babies receive the antibiotic treatment at birth. All right. That's it. That's the evidence, you guys. Like the evidence is dwindling. The studies that we used to use on antibiotic treatments is not the same as evidence that we're getting now because the bacteria is changing. Our prenatal care is changing. So why are we making it so routine and so law? Think about it. I am not telling you to not get this treatment if it's something that you feel is worth the risk. Like if the risk to your baby, maybe you don't live in an area that you get good care. Like if you did get it, well, we'll go into that in a minute. I'm getting ahead of myself. I know it's in my notes, right? That's why I can't go off topic. That's why my shows are always an hour long because I can't stay in my lane. But that's the evidence, guys. So just remember, let's talk about the downsides of getting the antibiotic because we need to know. We need to know what are the risks of taking this antibiotic, of giving it to our baby. Why? We know it works, okay? We know the ointment works. We know the antibiotic treatment works for the most part. It has worked. It's becoming less and less effective, but it does work. Great. But why else would a parent decline the ointment? So the ointment itself can cause irritation, redness, and in some rare cases, like I mentioned, it can cause a blocked tear duct, resulting in chemical conjunctivitis or pink eye, ironically enough. And I just mentioned it, but just repeating it so we can remember. It's really uncommon though, honestly. It could interfere with the parent-child bonding because of blurring of the baby's vision. So this gunky ointment in the eyes, it could make their vision even worse than what they already are. Babies, they can see your face when they're at your chest or breast level. So that's the distance that they can see. And it's not even that clear, right? It's kind of like how I see without my glasses, but they can make out your eyes and your mouth and your nose and your facial expression, which is so important. When they see the voice that they are so used to coming out of this mouth, they can kind of, I'm safe. I know this voice. This is where it's coming from as they move their mouth. The smiles, they're going to imitate that even right after birth. So important as you're breastfeeding or you're laying them on your chest that they see you. So a lot of parents are not going to want like their first feeding or those first moments or the first few hours or at all to blur that vision, even for that small amount of time. They just don't want it, right? They also don't believe that they're at risk for any severe case of, gonorrhea or chlamydia infection because they're testing negative and they're in a monogamous relationship. Or they're having a scheduled C-section or a C-section where their water hasn't broken yet. Maybe they've been in labor, their water never broke, and now they have to go for a C-section. They didn't they were kind of on the fence about the ointment. And you're like, hey, you know what? Since I'm not having this baby vaginally, she doesn't really need the ointment. We can wait. They may want to wait until they see signs or symptoms of infection and then just treat it instead of trying to prevent it. So that could be a reason. And then parents may just wish not to introduce drugs to their newborn that are just not absolutely medically necessary, right? They don't want to introduce any outside sources, and that's totally their decision, and I believe fine to an extent. But that's why I put if medically necessary. All right, so those are the downsides and reasons why some may decline, or you may want to decline. What about the alternatives? Okay, so almost at the end of this PIEDAY, what are other options that you have instead of this ointment? Well, first, you can understand, like I said, the signs and symptoms of ON in all its forms, right? Chemical, clogged duct, whatever it looks like. And you're going to know that you need to treat it immediately. And because the treatment with erythromycin is still highly effective. So if you didn't want to get it preventively and then you're seeing, the gunky eyelashes stuck together, then we can give that an antibiotic right away and prevent that, just in case it's gonorrhea and just in general, right? Any type of infection, we don't want it to get worse. Like I said, it's probably painful and irritating, and you didn't want him to have blurry vision, but now he can't even open his eye, So yeah, we can give you antibiotic right away. So you can also alternatively do what you can to prevent the infection by screening yourself prenatally. So test for gonorrhea and chlamydia, and most obstetricians do. It's part of your prenatal screening, and get treated. And then be very careful afterwards so that you're not reinfected before birth. Because if you got it, then probably your partner got it. So either abstain or make sure they're treated and then they test negative before you go back to intercourse. Yeah. And then maybe you can wait and apply it prophylactically, like to prevent it after the first feed. So if your thing is like, I want to be able to bond with my baby and see them, I want them to be able to see me clearly, then you can wait until after the first feeding. And that's what I usually do. So even if they say yes and they don't ask me any questions, I wait until after the golden hour, wait until after they've bonded, and then give the ointment. And then if the baby's in NICU, the baby has that time then to sleep, they can put the ointment in before you see them, and they'll be able to see you because it does clear up, within an hour. And then so that's one, is to wait. You can also wait until maybe after their first bath even. It's up to you. It's up to you when you want to give it. Maybe before you go home, whatever you feel. Another alternative actually is kind of cool, is you can use colostrum drops in the eyes instead. And that's been shown to reduce ON from non-gonorrheal, non-chlamydial bacteria, as well as inhibit gonorrhea and chlamydia growth. And it's been shown to do that on culture plates, which is pretty cool. This colostrum is amazing stuff. If it's the erythromycin I had mentioned before that's the problem, then you can talk to your doctor about different antibiotic that they could use. They could even use a providone iodine eye drop. So yeah. Then, of course, you want to discuss with your doctor and pediatrician your concerns and your preferences and any alternative plans that they suggest or that you suggest, because, it really should be reasonably declined if you are very low risk. All right. Again, I have the evidence-based article in the show notes. Go click on it, print it out, and take it to your doctor. Okay. And discuss it. Have your partner read it. This is just one of the medications. Take that time, prioritize it. Have them listen to this episode. It's important. Then the why of PIEDAY is you, right? So you got all the information. You understand the incidence and the evidence. You got why we want to give it to you. And then you know the alternatives. So what is going to be right for you? Where does your power lie? This is where it is. So Use this episode to learn more. Start that discussion with your partner, your midwife, your doctors. Are you basing your decision primarily because it is something that's just always been done? It's out of fear? Or are you taking the time to ask why? If it is necessary, and if it is something that you think is right for you and your baby. Okay. A lot of this episode is taken, like I said, from the evidence-based birth. So check it out. There's some questions in the article that I just want to cite right now that I like that you can ask your doctor. So use these. There's 4 questions that they cited. Of course, I can give you more if you're working with me, and you can come up with your own. But they say, hey, doc, can you go over my prenatal screening history and test results for infectious diseases? They're going to do a prenatal panel. They're going to test for HIV, syphilis. They're going to test for rubella, and then chlamydia, gonorrhea. So talk to them about the results. Figure it out and know what your results mean. Most likely, if you're positive, they're going to talk to you, but not always. They're going to use that in their plan of care and leave you out of it. It's crazy. Most likely they're going to, but then how does that increase the risk for your baby? How does it affect you? Can we discuss my personal risk status for infection with chlamydia and gonorrhea? So you've tested negative. Okay, great. So what's my risk of it then? What's the risk of passing it to my baby if I'm testing negative? If I test negative, is there still a chance? If I'm not having sex, is there still a chance that I'm going to pass it? Discuss it with them. I'm curious what they have to say, and then come talk to me so we can go over it together. Third question they have is, what will happen if I decide to refuse erythromycin eye ointment, and what alternatives are available? So again, does your state make it lawful and mandatory that you have to give the ointment? Or is it just something that they have to provide and offer you? What's going to happen if I decline it? They may just say, yeah, we're going to have you sign a refusal or that you're declining, and we're going to look for the signs and symptoms of infection so that we can treat it right away, right? Then the first one, if I decide to consent to preventative treatment, can we delay until after the first feeding or bath to allow bonding, right? You can, right? You can. So even this with evidence-based birth, there's things in here like using the word can I and can't I. I would say, would you recommend, right? I want to wait until after the bath. I really want to prioritize bonding and skin to skin with my baby. I would like to wait maybe after the first feeding. What are your thoughts on that? Get their thoughts. I always say the doctors are your expert medical advisors. Get their thoughts, get their recommendations. More than likely, you hired them because you want to use those recommendations. But sometimes you don't. I'm like, my tax guy, my finance guy, my coach at the gym, or my diet coach, they give me recommendations all day long, but they're not my boss. They're not my mom. And your doctor's not your dad, your mom. So what is the recommendation? And then take that very seriously. Take it into consideration. That's what you're asking. But can we delay? See, I'm just reading this right now, so I'm just I don't know. What do you think? What do you guys think? Do you want to give that authority to your doctor? Can I? Am I allowed? Am I allowed? Is it against the law? That's probably a good question. All right. So the article, I like it. I like evidence-based birth because it does also talk to providers as well. So it looks to how we're educating and how we're screening patients, how we're evaluating their risk status, and then what are we doing if the baby does develop an infection, right? Are you guys able to receive timely care, right? Or are you living far away? So if you take your baby and you're hours away from a hospital or a doctor, then that's something to consider, because if that baby has an infection, you understand it takes less than 24 hours for a gonorrhea infection to result in eye damage and permanent blindness, less than 24 hours. If that baby's sleeping, then there goes the whole night. Now you woke up and you're like, oh crap, it's been 10 hours. You haven't even noticed it. Then you notice little gunk. And now you're 3 hours away from the doctor. So now you got to get in the car and you got to drive. So now it's already been 15 hours. The damage might already be done. You just risked your baby's eyesight for this whole life. Poor baby, and then poor you. You're going to have to raise your baby. That's difficult with the thought that because you made that decision, if you just put the ointment in the baby's eyes, right? So what's your risk status? And the doctor and provider needs to understand that too when they educate you, right? They can't force you, I don't think, but they need to really strongly recommend and let you know this. And if they don't, well, I am right now. Okay. So understand your risks. It's so important. It's important for you. It's important for your doctors. It's important for nurses, right? So look, to wrap this all up, we just went through the whole PIEDAY. At the end of the day, you guys, this treatment is so routine, right? But as always, we want to ask why. We want to allow for team decision-making with a more individualized care, especially for something that evidence is now showing to be less effective. It's for a very rare but serious disease. So you've got to see, do the benefits outweigh the risks for everybody? Do they for you and your baby? This is just one more decision to check off that list as a parent and one you want to make before your baby is here. Okay? All right, that's it. That's your erythromycin. It's way more than I am able to tell patients at the bedside. I wish I could explain all this to them. I'm so happy that you listened. If you have any questions, you know where to reach me, Colette@myfriendsandnurse.com. Email me directly. Find me on Instagram at myfriendsandnurse. Go to my website, myfriendsandnurse.com. You got this, okay? Next week, we have a wonderful interview. I can't wait for you to join us for that. Oh, also, in 2 weeks, I'm going to hold off on the vaccine, but I do want to talk about vacuum and I'll touch on forceps too. So vacuum deliveries and forceps are pretty important stuff. And then, yes, next week is going to be with Lindsay. So hypnobirthing. Yay! Super excited. If you are curious about hypnobirthing, you don't want to miss it. All right, guys, have a great one. Bye. Thank you for listening to My Friends and Nurse presents the Birthling Podcast. We hope you enjoyed today's episode and found it valuable. Before we go, a quick reminder. The information shared on this podcast is for educational purposes only and should not be considered medical advice. Always consult with your healthcare provider for any medical concerns or questions. If you enjoyed the episode, please subscribe, leave a review, and share it with your friends. Your support helps us reach more people and continue to bring you great content. Until next time, stay healthy and stay informed.